Greetings, everybody. Welcome to Weill Cornell Medical College. We're so happy to have the opportunity to host you here at our campus. I'd like to begin by acknowledging the tremendous support of Senator Gillibrand, Senator Blumenthal, and Congressman Gibson for this very important initiative for leadership on this issue. I'm an immunologist myself and a rheumatologist, so I've treated patients who have Lyme disease and other tick-borne diseases and have come to appreciate that most physicians, or many physicians, are not aware of the potentially devastating and long-term consequences of Lyme disease, particularly on the nervous system. So here at Weill Cornell, we are committed to expanding our medical research enterprise in this disease and actually in many other diseases that are still represent areas of huge unmet medical need. And if you walk outside, you'll see our new research building, the Belfer Research Building, just across the street, which is going to double our research space here at Weill Cornell Medical College, and is going to open at the end of the year. And we're hoping to recruit 30 or 40 new, wonderful medical researchers. Now, we happen to be in the midst of some real champions for medical research in this audience today, and especially among the elected representatives, those members of Congress who are also here. For those of us who have devoted our lives to medical research, these are obviously very challenging times. I don't have to tell you that. We're experiencing a dramatic pullback of funding for medical research and under sequestration, which is going to negatively impact this country in a number of different ways and impact the scientific medical community. It will certainly hinder our pursuit of new cures and medical treatments for diseases, and for diseases that are most serious today, such as cancer and Alzheimer's disease. It's going to lead to a loss of jobs because the medical research enterprise is an economic engine for revenue. For every dollar that we get from the NIH, the return on investment is $7.50. So this is going to lead to a loss of jobs and career opportunities. And most important, it's going to delay breakthroughs in the treatment of really important diseases, such as Alzheimer's disease, that are ultimately really going to break down our healthcare system if we can't find new treatments and discoveries for them. So we in the academic medical community, and I speak not just for Weill Cornell, but for all academic medical centers, are obviously taking steps so that we can continue to fulfill our tripartite mission. We need to educate the next generation of physicians in our medical college, and we get wonderful, wonderful medical students. We had 7,000 applications this year for 100 slots. And we need to continue to expand our medical research enterprise to discover new cures. And finally, and most important, we need to continue to provide the highest quality of care for our patients, because whether you're in the laboratory doing discovery or at the bedside of a patient, the patient is the center of everything that we do. So I want to thank those of you in the audience who have done so much on your own to enhance and drive forward this particular area of research and other areas of research by your generous donations to fight tick-borne diseases and other diseases. We really need you now more than ever. Our new Belfer Research Building is an example of the generous philanthropy of our donors, particularly to Renee and Bob Belfer, whose name is on the building. The expansion at Weill Cornell Medical College will more than double our existing research space, and I think is a testament to what can be done with the input from the community. So I'm very happy to host all of you here today as you continue your fight against tick-borne diseases, especially Lyme disease. And as a medical professional, I'm really very grateful to you all for all that you do in public health and in medicine. It's now my pleasure and honor to introduce our New York Senator, Kirsten Gillibrand.
I am very grateful to Dean Glimsher for her extraordinary leadership and what she's already done here in the short time she's been with us. She's making a difference, and I think we are so lucky to have her here in New York. I also want to thank the Tick-Borne Disease Alliance and Weill Cornell Medical College for joining us and hosting this important forum to basically increase public awareness and discuss a path forward to fight against tick-borne diseases, including Lyme disease. I want to thank Senator Blumenthal for his leadership in Washington. He has been an incredible champion for keeping families safe and combating these serious diseases that are really affecting too many of our loved ones. And I feel so blessed to have him working alongside me in the Senate. Thank you, Dick, so much. I also want to thank Congressman Gibson for joining us. Congressman Gibson has been a great advocate for upstate New York, where we have a lot of tick-borne diseases. He has been a critical voice in Washington when it comes to addressing the health and well-being of our families, and I appreciate his bipartisan support. It makes quite a bit of difference when we look in Washington and we know how much is broken. There are areas where we really can come together and make a difference, so thank you, Congressman. Thank you. And of course, I have to thank Weill Cornell Medical College for hosting this important event today. And we are live streaming. I don't know if folks know that, but Ulster Community College is watching as we speak now, which is terrific. New York City is truly home to the finest medical institutions in the world, and none are better than Weill Cornell, which is home to one of the nation's top-ranked medical research centers. The entire staff here is dedicated to improving and saving lives every single day. So thank you for your extraordinary contributions to our city and to our world. We really appreciate what you do. It's great to see some of the world's greatest experts here today to talk about this issue. I really look forward to hearing their invaluable insights into the important topic of tick-borne diseases. And we're here today to discuss the growing epidemic of these tick-borne diseases, from parks in all of the 5 boroughs of New York City to the beaches of Long Island to the farms of upstate New York. Tick-borne diseases are growing and a growing public health crisis. For too long, it is a crisis that has largely gone ignored. According to the U.S. Centers for Disease Control, Lyme disease remains the fastest growing vector-borne infectious disease in the U.S. The CDC reports 24,000 cases of Lyme disease in 2011. That acknowledges the actual number may be over 10 times as high due to underreporting. Another highly alarming factor is the growth of the diseases. It's the presence in our blood supply. We need to ensure that our blood donor supply is thoroughly tested and free of these diseases to reduce senseless infections. Ending these diseases starts with prevention. But with no vaccines to prevent Lyme disease or the co-infections, we have a very long way to go. We know that patient outcomes for tick-borne diseases are measurably better when these diseases are caught early, but there is disagreement about proper diagnostic protocols and a lack of awareness about these diseases. And each of the tick-borne diseases presents us with a complicated set of symptoms that varies from person to person. Difficulties in identifying and diagnosing these diseases then lead to more difficulties when it comes to their treatment. In fact, there is no standard and wholly effective treatment. Therefore, as with all progressive diseases, the patient will get sicker the longer the disease is left untreated. With a 100% reliable diagnostic test and without a cure, without 100% reliable diagnostic test and without a cure, education and awareness among doctors and patients paired with research and heightened attention to this issue are absolutely essential. That's why I'm pleased we are together today to listen from those who have seen these diseases firsthand and know what's actually at stake in this fight. Clearly, we have to have a better strategy than just checking ourselves and our kids when we come in from a day of play in a rural area or at a park. We need to do better in educating our families on the risks and emphasize prevention so they know how to protect themselves. I look forward to working with Senator Blumenthal and reintroducing our bill, the Lyme and Tick-Borne Disease Prevention, Education, and Research Act this spring. Now, our bill is just the first step by the federal government to save more lives and one day rid us of these tick-borne diseases. What the bill does is establish a tick-borne disease advisory committee. It streamlines coordination between federal agencies and private organizations. It coordinates increased research and development around Lyme disease. It develops more accurate and time-sensitive diagnostic tools, and it increases public and physician education and establishes reports on Lyme disease that evaluate guidelines and research. I think that if we can work together, guided by a common purpose, we can make progress, and we can give our families and communities greater hope that we will learn how to fight against these diseases. I want to now introduce our next speaker, which is Senator Dick Blumenthal, who's going to tell us about some of his thoughts.
Thank you. First, thank you to Senator Gillibrand for her leadership on this issue. When I arrived in the Senate 2 years ago, she was already helping to lead the nation on this very, very important public health issue, and I was very pleased to join with her as a partner in spearheading the legislation that she's described, and really am grateful to her for her strong and steadfast leadership on this issue. And thank you to Weill Cornell, which is such a great educational and healthcare institution, and Dean Glimcher, Andrew Tisch, who is with us this morning, Bob Belfer, whom I know well. Thank you all for contributing so much to American public health at a time when we need it so desperately. I have a brother who is a doctor. As Dean Glimcher knows, my brother has been, he's a younger brother, but he never tires of telling me how little I know about healthcare. So I stand here before some very eminent physicians and specialists with a great deal of humility and some trepidation, but also because of our panel, which is composed of such a distinguished group. Let me just say, though, having paid deference, excuse me, to the experts in this room, I believe when the story of Lyme disease is written, and when the cures are developed and we conquer this dreaded, pernicious disease, it will be the story of patients standing up and speaking out, seeking to be heard, and insisting on the kind of research and consciousness that has brought us so far today. And I want to therefore thank David Roth, who is here, because he has been one of those advocates who has stood strong and spoken out so vigorously. Thank you, David, for all that you have done. And thank you to the patients. They may not be represented here, but the patients whom I have seen for 15 years and who brought me to be involved in this topic at least 10, 15 years ago. I became involved because people suffering from Lyme disease, many of them with children, families, where more than one family member was afflicted with it, came to me and said, they're not listening, meaning the people in power, their own doctors, were not listening to them. And Dr. Fallon was one of those who did listen and who has done some remarkable research in this area. But one of the purposes of our bill is to make sure that Washington listens to patients. The advisory committee that was described by Senator Gillibrand will have patients, give them a voice, a seat at the table, really for the first time. And my view has always been that we need to listen to the patients, but most important, and I really stress most important, allow the doctors to prescribe what they think is important. As a senator, as an attorney general, I know, not just from my younger brother, but from my own experience, that politicians, insurance bureaucrats don't know as much as the docs and the patients. And that relationship is so key to all of these decisions about what should be treated and what should be diagnosed. So when I became involved, insurance companies were failing and refusing to provide coverage for treatment of Lyme disease. And as I listened to the patients and the doctors who said, you know, we think that certain forms of treatment should be prescribed. These are reputable physicians, well-known, well-regarded, and the insurance companies basically said no. I worked for a mandate, which we now have in Connecticut, that provides that insurance companies have to cover Lyme disease treatment. Not what the politicians say should be covered, but what the doctors say should be covered. And that ought to be the rule in all forms of treatment, that the insurance companies and government officials should trust and respect what the doctors say. Then, as now, there was too little reporting, in fact, underreporting of Lyme disease. In fact, in some ways, in my view, that situation, at least in some states, has become worse rather than better. Underreporting is a major obstacle because it impedes public consciousness and response of responsible officials in the public and the private worlds. And then, as now, there was a conflict professionally. I was going to say disagreement because that is a somewhat more diplomatic and respectful way to talk about the differences of opinion. But within the professional community, clearly there are continuing differences. And as somebody in public life, not a doctor, I respect those opinions, and it ought to be for the medical profession to resolve them. But in the meantime, the doctors who say that certain forms of treatment are appropriate should be respected as well. And you know, then as now, there was really a need for physician education. The folks in the trenches, the family physicians who see the symptoms of Lyme, all too often are not sufficiently aware or educated about the need to take additional steps. And that is said with, again, the greatest respect for the profession. It's simply a matter of physician education and awareness. Still, in many parts of Connecticut, of all places where Lyme began, physicians are all too often mistaking those symptoms for other things, particularly where children, young people, are concerned. And all too easily, a doctor or a parent can say, well, you know, excessive tiredness or pains or other kinds of conditions associated with adolescence or youth, particularly in school, are unrelated to potential Lyme. And as Senator Gillibrand has said so well, there's a need to take that next step in terms of generating public consciousness. We have in our nation today, literally, in my view, an epidemic of Lyme. It is spreading beyond Connecticut and the East Coast to the south of the United States, to the west, and that is the reason why I see a growing momentum in the Congress for action. This epidemic of Lyme will not go away unless we act to stop it and take preventive measures, as well as more research, which is desperately necessary, and raise public consciousness and physician consciousness about this problem. I want to introduce to you someone who has really been a leader in this area as well. Congressman Gibson from the 19th District of New York represents an area of his state that borders mine, New Milford up to Salisbury in Connecticut, an area which is inseparable. You know, tick-borne diseases, maybe not surprisingly, don't respect state borders. And I want to introduce him. He's a great public servant. He's a decorated war veteran and a person of tremendous distinction and dedication, and I'm proud to introduce him today. Thank you.
Well, thank you, Senator, for that warm introduction, and to both our great senators for their leadership on this very important issue. And, you know, as an alum, as a Cornell alum, I'm proud of my alma mater for leading the way here. Thank you, Dean, for your leadership and for organizing this today. To our panel, a distinguished panel, looking to make a major difference on this every day. And, you know, my experience with this is that those that come to meetings like this, in one form or another, they are very strongly emotionally tied to this issue. We do have some gracious donors here today. Thank you for making a difference. But beyond that, sufferers or family members of sufferers or dear and close friends of those who have been victims. And towards that end, we are also, as the Senator mentioned, live streaming today up in Ulster County, part of my district. Chris Fisk is there leading that. She's the mom of someone who has suffered and appreciate her leadership. And, I will tell you that shortly after retiring from the Army in 2010 and moving about what was then the 137 towns of the 20th Congressional District, hardly a day went by that in the throes of listening as far as job creation and a whole number of issues, hardly a day would go by that I wasn't grabbed by the arm and was said, what a scourge, a public health scourge Lyme is. And having been gone from the area, of which I grew up for 24 years, I focused on this, my office is focused on this. We've made some strides. There's so much further to go. But through your advocacy, we have made some progress. $8.75 million last year in appropriations for better testing. How can it be that a country as great as ours, we don't even have a test that picks up half the cases of Lyme? We simply have to do better than that. Now, encouragingly, we did a hearing last year where we started to hear that the impact of some of these investments is starting to take root. That we look like we may be on the verge of getting a better test that moves beyond just drawing and looking for antibodies, which we know with the spirochete can hide. As the Senator mentioned, a pernicious disease that comes in and out of view and leads to lifelong chronic conditions. Better testing. Also, that we had a symposium last year. Over 500 individuals came to Skidmore. And we had regional and national experts. Some of the folks here today, and in fact, Holly Ahorn, who's in the front row here today, is a researcher making a tremendous difference on this, who has published on just how underreported our cases of Lyme are. And other medical professionals who came and talked about the co-infections that exist with tick-borne diseases. I think that this will help bring us together. Sadly, a bifurcation now in the medical community on this issue when we really need people to be united. But I'm hopeful that the latest research will bring us back together. Let me offer two things that I hope will be goals for this Congress, things that we can work together in not only a bipartisan but a bicameral way. The first has already been mentioned, and that is this Tick-Borne Advisory Group. No, this is not just another commission from the United States government. This framework was the same type of approach that made a difference for AIDS. This public-private partnership where we get all together, the experts, certainly in the medical field, but also across the levels of government, federal and state, victims of this scourge. And we hear from all of them. We streamline our research. We also hold accountable research, because part of the issue we're dealing with is what I think are some of the most contributing scholarly works are not even being published. They're being held up. And I think this Tick-Borne Advisory Group is going to help bring to light, as was mentioned, illuminate this very important issue. Number two, and that is the guidelines, quite frankly, that are coming from the CDC. It's been mentioned, the Lyme literacy issue that we're having. In my research, I really believe that just how narrow these guidelines is a major contributing factor to this. The Lyme illiteracy issues that we're having for doctors that are just overworked and tired and really not getting a chance to see some of the research, some of the experiences that are going on out there. And in addition to that, we have some successful work being done in the experimental field, but we don't have a repository to gather that information because doctors are loath to send that in because then they're outside the guidelines and expose themselves legally. So working together. And then finally on this piece with regard to the CDC guidelines in healthcare insurance companies. They're just not, Connecticut, great work there, but just nationally, this is not being covered in a way that our constituents really need. It can cost up to $1,000 for the first consult for our constituents who are looking to get a treatment for this, no coverage. Who can afford things like this? And in my engagement with the insurance companies, they have said they're hiding behind these guidelines. And they're saying that, well, if the guidelines change, then it would be reasonably reasonable to conclude that we change our policies. So myself and a couple other colleagues on the House side, we've written on this. The standards, the protocols are that these guidelines, writ large, should be reviewed every 5 years. Well, it's been more than 5 years with regard to these Lyme guidelines, and we don't have the update. Yet, through the senator's work in Connecticut, there were studies that were forthcoming that we know that these guidelines should change. So I hope that in a bipartisan and a bicameral way this year, we can work together to write to the administration how important it is that we change this, because, ladies and gentlemen, I firmly believe we can make a difference, but we're not anywhere near where we need to be. There's a long way to go, but I appreciate the leadership of these senators, for our experts here today, and for you to be engaged, because we're going to continue to march forward. I'm honored to be with you. Thank you.
Thank you, Congressman, for your passion and drive. I really appreciate it. The next speaker I want to take a moment to introduce, because sometimes one conversation, one person can change the outcome of a major issue. And it was my conversation with David Roth that made me so interested in finding solutions. And David and I knew each other from college, and he's a successful investment banker. Is that what Blackstone is? I don't know. Just private equity.
Investor.
Yeah, he's an investor. Very successful businessman who I loved and admired in college, thought was smart and funny and all the great things. But when he called me, when I was first appointed to be senator, he told me his life story, and he told me how tick-borne illnesses had devastated his life and how he was treated through his diagnosis and his medical treatment. And I couldn't believe what I was hearing. And this was just one story of many that I've now since heard. But he really opened my eyes to what the challenge really is. And he's someone who didn't just sit on his own difficulties and say, it's just my bad luck, or, I just had a tough time. He recognized that thousands of people have had a really tough time. Hundreds and hundreds of families had gone through exactly what his family had gone through. And he was determined to make a difference. So I just want to thank David for using your own personal challenges to broaden this conversation into a nationwide, international conversation about what has to be done for families who are suffering so badly today. And he really used a lot of his great networking skills. He is the co-chairman of the board for the New York-based Tick-Borne Disease Alliance, because he wanted to create a grassroots movement, an advocacy movement that could actually make a difference. And I just want to thank you, David. You're going to be our moderator, but I want to thank you personally for telling me your story and letting me be an advocate for not just you, but for all the families suffering. Thank you.
Hopefully this is on. Good morning. Thank you so much, Senator, for that warm introduction. Very kind. So thankful for your leadership and the leadership, Senators Blumenthal and Congressman Gibson and others who are helping in this fight. I, as mentioned, am a managing director at Blackstone and co-chairman of the Tick-Borne Disease Alliance. I'm also a sufferer of ongoing symptoms that stem from Lyme disease and Babesia that were diagnosed in the summer of 2010. Before I start, I want to thank Weill Cornell. I want to thank Dean Glimsher and, of course, our esteemed senators and congressmen for their continuing leadership in these issues around tick-borne diseases, specifically for the support of legislation that's been described already. I also want to welcome our friends up north at the Community College at Ulster, and particularly mention Chris Fisk and Holly Ahern, who helped quite a bit in setting this up. I thought I'd start by showing you the historical and estimated future burden of Lyme disease in the U.S. alone, and it should be mentioned that these are worldwide problems. We talk about Lyme disease, it's the most prevalent of the tick-borne diseases, but there are over a dozen other diseases, and we are finding them every day. There was one announced in the last few months. that I think we'll talk about later. So this shows that there were, including confirmed plus probable cases, 33,000 reported cases in 2011. And the CDC historically has stated that there's anywhere from 6 to 12 times more cases of actual than reported illness. Given the restrictive definition of Lyme disease that is really was designed originally for reporting criteria, not really for diagnostic purposes, it's very possible that these numbers are understated. But just given 12 times and assuming a continued growth of 6% a year, which is what the growth has been since 1994, we're looking at a situation where by 2020 we'll have over 600,000 cases a year, many of which are untreated, unrecognized, undiagnosed. And of that, a meaningful number will go on to have chronic symptoms. We know that those chronic patients, the cost associated with that, both in terms of their own productivity, the patient's impact on their life, as well as the actual cost to society of the treatment, runs well into the billions of dollars. This is a very, very significant ongoing health crisis and very much an epidemic. This is why we at the Tick-Borne Disease Alliance are promoting awareness of Lyme and other tick-borne diseases and the need for additional research funding for things like better diagnostics and treatment. It's also why we're here today, and again, thank you for everybody on this panel. I am humbled by the opportunity to speak with professionals of this caliber. Today's format will consist of set presentations by a panel of esteemed guests from the medical and science community, followed by a brief Q&A from me. I will do my best. I apologize in advance, not being a scientist or a doctor. And then questions from the audience here and in Ulster. Our panel consists of the following: Dr. Roy Gulick to my left, on loan to us from Weill Cornell, where he's the chief of the Division of Infectious Diseases and a practicing clinician. He's also known for his work in the area of AIDS research. John McPherson. John is a longtime sufferer of Lyme disease and a nationally syndicated cartoonist. Dr. Richard Osfeld, senior scientist and disease ecologist at the Carey Institute of Ecosystem Studies. Dr. David Leiby, head of transmissible diseases at the American Red Cross. And Dr. Brian Fallon, director of the Center for Neuroinflammatory Disorders and Biobehavioral Medicine and the director of the Lyme and Tick-Borne Disease Research Center at Columbia University. In light of the limited time we have with our guests, we're going to begin without further ado with Dr. Roy Gulick.
Thank you. Esteemed guests and colleagues, I'd like to also add my welcome to Weill Cornell today, my home as well. What I'd like to do is provide a brief medical introduction to tick-borne diseases. Going the wrong way. So there are a number of diseases that ticks may transmit to humans, and this is a partial list, and it's a complicated list. Viruses can be transmitted from ticks to humans, and an example is tick-borne encephalitis, which occurs commonly in Europe. Parasites may be transmitted from tick to human, and babesiosis is a good example. And finally, bacterial diseases can also be transmitted from ticks to people, and there are a number on this list, including Lyme disease and Rocky Mountain spotted fever. Tick-borne diseases vary in many ways. Rocky Mountain spotted fever, for example, despite its name, is most common in 5 U.S. states: North Carolina, Tennessee, Missouri, Arkansas, and Oklahoma. You'll note that none of those states are actually near the Rocky Mountains. It's transmitted by the dog tick. It was first described in the 1920s, so has been with us for some time. Contrast that with the last disease listed here, 364D rickettsiosis, which was only recently discovered and is confined to California. 3 tick-borne diseases that we think a lot about here in the Northeast are also listed for you here and are all transmitted by the deer tick. And those are anaplasmosis, babesiosis, and Lyme disease. In fact, one tick can transmit all three of those diseases at the same time. I'm going to confine my further remarks to Lyme disease, which, as you've heard, is the most common tick-transmitted disease in the United States. It was first appreciated in 1975 when there appeared to be an epidemic of arthritis in children in the town of Old Lyme, Connecticut. And it was the mothers of these children who really brought these cases to medical attention. The causative organism for Lyme disease was named for its discoverer in 1982, and it's Borrelia burgdorferi. 95% of the cases of Lyme disease are shown for you here occur in two areas of the United States, the Northeast, from Virginia up to Maine, and in parts of both Minnesota and Wisconsin. Lyme disease has been reported from every one of the states, with the exception of Hawaii, but almost all of those cases have had contact in areas, either the Northeast or the Midwestern states I mentioned. How does one diagnose Lyme disease? Well, the first step is just to be aware of its existence, and physicians do need to be aware, and so do patients and families. Residing in an area where Lyme disease occurs in the tick population or recent travel to that area is a key point in the diagnosis of Lyme disease. There are three stages: early localized, early disseminated, or late disseminated. The early localized most often manifests as a characteristic rash called erythema migrans. Erythema, the medical term for red. Migrans, as it sounds like, is spreading or migrating. Often it's described as a bullseye lesion, which you can tell from the picture. In the center of the bullseye is often the place where the tick bite occurred in the first place. Approximately 75% or more of patients with early Lyme disease will present with this characteristic rash. Yet only 25% of them will remember being bitten by a tick. And why is that? Well, you can see the size of the deer tick is very, very small. Early disseminated disease means that the bacterial infection is now progressing throughout the body. There are characteristic clinical syndromes, which I'll mention in a minute, and the blood test, or serology, which measures an antibody, that is the body's response to the invading organism, is usually positive in this setting. Late disseminated disease, not to be confused with chronic Lyme disease, which I'll mention in a minute, also has characteristic clinical syndromes and almost always has a positive blood test associated. So what are those characteristic syndromes? As I said, in early localized disease, which occurs within 3 to 30 days of the tick bite, the characteristic erythema migrans rash is most characteristic. In addition, there may be associated symptoms that go with that: fatigue, headache, myalgias, which are muscle aches, and arthralgias, which are joint pains, can all be associated. In early disseminated disease, which occurs weeks to months after the tick bite, a person can actually have multiple erythema migrans lesions. And I remember a case from my fellowship in Boston of a sea captain from Nantucket who had literally 12 erythema migrans lesions all over his back. This can also affect end organs, musculoskeletal, so joint pains, neurologic and cardiac diseases can occur, and other rare diseases where Lyme disease can affect the eyes, the kidneys, or even the liver. Late disseminated disease occurs months or years after the tick bite and most often presents as an arthritis of a big joint like the knee. And this can be intermittent or persistent. And there are also rare neurologic conditions that can occur. The CDC has a case definition, and as was mentioned, this is for reporting, not necessarily for diagnosis. And they require either the presence of the characteristic rash or one late manifestation, either cardiac, musculoskeletal, or neurologic, plus the laboratory confirmation. Again, even the CDC website cautions not to use this for diagnosis, but for reporting. The treatment of Lyme disease. The good news is about 90% of people or more will respond to current treatments with resolution of their symptoms. Early Lyme disease is treated with oral doxycycline or an alternative such as amoxicillin for up to 3 weeks. The end organ damage, either neurologic, cardiac, or arthritis, if it's considered to be mild disease, can be treated with that same oral antibiotic for perhaps as long as 28 days. However, more severe syndromes, either neurologic, cardiac, or arthritis with neurologic symptoms, require intravenous treatment with IV ceftriaxone, as you see, for up to 28 days. Again, many people will respond to this with resolution of their symptoms. Occasionally, people will have recurrence of symptoms and require a second treatment course. Multiple treatment courses are not currently recommended in practice guidelines. The practice guidelines you see here are from the Infectious Disease Society of America. They were published in 2006 and re-reviewed in 2011 and endorsed without change. One thorny issue is the post-treatment Lyme disease syndrome, formerly called chronic Lyme disease, although that term has essentially fallen out of favor. These are a group of people who have chronic symptoms, most often pain, fatigue, and/or neurocognitive changes following a documented treatment of Lyme disease. That definition is controversial in and of itself. The word syndrome is a medical term for a constellation of symptoms where we don't know the underlying cause, and that would be true here. In fact, the cause is unknown. Some have speculated that this could be an autoimmune reaction, and there is precedence in the infectious disease world for this. Probably the best example would be rheumatic heart disease that occurs after a streptococcal infection. This is an active area of research. Would antibiotics help people with prolonged symptoms post-treatment for Lyme disease? That was addressed by 3 randomized NIH-sponsored clinical trials where people either received antibiotics or a placebo. And you can see the references there, including the third one and most recent, which is by one of our co-panelists today, Brian Fallon, who used the most prolonged treatment of IV antibiotics. The results have been reviewed, and the benefits weighed against the risks. What were the risks in some cases of receiving prolonged therapy? Well, there were allergic reactions to the antibiotics, there were catheter-related problems, and colitis, and at least 1 or 2 deaths have occurred in patients who underwent prolonged treatment in these scenarios. This has been reviewed by professional organizations, including the Infectious Disease Society of America and the American Academy of Neurology, and they concluded that the risks really outweigh the benefits of prolonged antibiotic therapy, and that's not currently recommended. Prevention has been mentioned, and that is a key part to tick-borne illness, preventing the bite in the first place. So avoiding places where ticks live, using insect repellents, wearing long pants and socks, performing tick checks. And it turns out that a tick cannot transmit Lyme disease within 24 hours. So if ticks are removed promptly, that is an effective way of avoiding Lyme disease. And finally, the last bullet, administering a single dose of doxycycline was a strategy that was looked at and carefully assessed in a controlled clinical trial published in the New England Journal of Medicine in 2001. And it showed just 1 dose of doxycycline within 72 hours after a tick bite in a person who resided in a Lyme disease area could reduce the risk of Lyme infection from over 3% to less than 0.5%. So this is widely adopted. I just wanted to share, I am a physician scientist. I've treated dozens of cases of Lyme disease and its complications. Most of my research has been in the field of HIV, and I just wanted to echo something that was said before. The best way to address an illness is really to bring all partners under a single umbrella. And I think bringing in the community, bringing research, industry, government, and foundations all together is the best way to make progress with an illness. I'll stop there. Thank you.
It's a great honor for me to be here. I am not a medical professional as the folks on either side of me are, but I'm here as a patient who has been experiencing Lyme disease symptoms for a very long time. I remember waking up in 1998 with a very large welt on my stomach, probably about 5 inches in diameter, and I thought it was a spider bite and just kind of continued with that frame of mind. But about a week later, I came down with the classic flu-like symptoms, and within a couple weeks, I had achy joints and many of the early classic Lyme symptoms. At that stage of my life, I really did not know anything about Lyme disease, so I didn't pursue Lyme disease. But I did begin to experience brain fog that is often accompanied with Lyme disease, and it bothered me to the point that after several months of just feeling like it was very difficult for me to think and get things done as I normally would, I came to see a doctor here in New York at Columbia Medical. And he spent a good 2 hours going through all of my symptoms. And again, this was in 1998. And he eventually sat down his pen and leaned back in his chair and said, "I think you have Lyme disease." And I had barely even heard of Lyme disease, but he was convinced that I had it long ago. He gave me, had me take the Western blot, and I believe the ELISA was around back then, but I was tested for Lyme disease, and as often as the case, I came back negative for Lyme. And after that, we searched down other avenues to try to find out what was bringing on this constellation of symptoms. I never really did nail down anything. But during that time, I kept enduring more and more symptoms through the years. I started to get very intense burning sensations in my feet as though I was being stung by bees, numbness in my hands, face, legs, and arms. I had numbness from the waist down one time. I mean, I could still walk, but my legs were numb. And I went to the hospital, and I remember them just going, it's stress. You have stress. And the ER doc said, "Is there any stress in your life?" I said, "Yeah, I'm stressed out because I could barely drive to the ER because my legs are numb." But I followed up with my GP, and he said the same thing. "You're under a lot of stress." And one of the symptoms that I had right from the start was facial paralysis. Both sides of my face are still numb to this day. And my doctor looked me in the eye and again said, you are just under a lot of stress, and that's why your face is numb. And I even said, "Well, you're a doctor. You've got to be under a lot of stress. Isn't your face numb also?" "I handle my stress better than you do," was what he said. So for years, I continued, and the symptoms would ebb and flow, but I got tinnitus and blurred vision and had trouble sleeping and night sweats, and I have to write them all down because there's many of them, but I won't read them all. Spasms at night, until I really began to realize that something was askew, and didn't quite know what to do with all these symptoms. Then at about that time, I got another tick bite, and this one was a tick embedded in my lower back. And again, still at that time, I didn't know anything about Lyme disease. I pulled the tick out and called my same GP, and he told me that there's nothing to the Lyme disease hysteria, and that unless I saw a big bullseye rash, to not worry about it. So I just flushed the tick down the sink and went on with my life. But at that point, my symptoms got very severe, to the point where I began living much of my life from bed, experiencing very severe fatigue and extreme pain to a level that I simply did not think was possible in a human body. I learned so much about pain during that period of time from either neuropathy or bone pain, and sometimes both of them at the same time. So it felt like I was on fire and being run over by a steamroller, and tried to explain that to friends who still couldn't quite get that, but I don't suppose anyone could. But I'm saying that not to get sympathy, but to try to get those of you who don't have Lyme disease and have friends or relatives that do, to comprehend what it's really like and how extremely debilitating this illness is. I think one of the very hardest things for me has been the brain fog, where I simply feel like there is a gray veil between myself and those closest to me. I can be with my family members, but feel like I am a mile away. And no matter how you try to get closer and feel more attached to people, you just feel this sort of vague detachment from what's going on around you, and it's a very, very creepy sensation. About 2 years ago, I did hook up with a very esteemed Lyme doctor who has helped me to make some very good strides in reducing my symptoms, and I am living a much better lifestyle than I have been since early on 2 years ago. Things are improving, but I still deal with many very severe symptoms along the way. They come and go, but they're always there. There's never a morning where I wake up and really say, I feel good today. Might be a little flash during the day where I feel pretty good, but it's an ongoing and very difficult disease to endure. I've gotten to know many, many people with Lyme disease throughout the years, and it has been a real eye-opener for me to see all the different symptoms that they deal with. And I hope I can just give some credence to all that they are enduring and speaking out about what this illness is all about. What's ironic to me is that if this disease and these symptoms were being caused by some form of human enemy, the whole country would be in such an outrage that we would stand up and stop this in an instant. But because it's being caused by a little tiny bug, we seem to be turning our heads the other way. And we really need to turn and attack these ticks and take it right at them. And I think many of the speakers here have already expressed that, but as a patient, I agree. It's time to really tackle this issue and not let it proceed any further. In the midst of my pain, I drew up a cartoon. Let's see if it will pop up here. You can see it from there. I don't know how well you can read it, but I'll read it. Your husband's rash is too irregular to be Lyme. This is what a Lyme bullseye looks like, as per the American Archery Association. And all I'm trying to say with that is there are just so many different ways of interpreting what is going on with Lyme disease that a simple thing that's just off a little bit, and some doctor can say, no, that's not it. And I'm here to say, well, you know what? I think it is. Thank you very much.
Hey, David, I just need this to. Thank you. I'm Rick Ostfeld, and I appreciate the invitation to be here. I'm honored to be among these guests. The United States, people of the United States have experienced wave after wave of the emergence and spread of tick-borne diseases. We've heard quite a bit about Lyme disease, which first emerged in the 70s and began to spread very rapidly in the 1980s. About 10 years later, anaplasmosis emerged and began to spread throughout various parts of the US. And then babesiosis first appeared a little earlier, but began to spread rapidly in the 2000s. But now there's a new kid on the block, and that is a pathogen called Borrelia miyamotoi. We don't have a name for the disease it causes yet, so I've simply put B. miyamotoi infection. And there are no images that I could find for this particular pathogen, so I put up this whimsical image of what it might look like. And we don't know whether this disease is going to emerge and spread, but from the track record of other tick-borne diseases, it seems quite likely. It's already been mentioned that Lyme disease is the best known of these. It first was a nationally notifiable disease in 1982, and the number of cases reported to the CDC have grown from a few hundred in the early 1980s to a few tens of thousands in the past several years. And again, it has been mentioned that this represents some degree of probably large underreporting of the actual number of cases. Human anaplasmosis arose in the mid-1980s and has grown in what looks to me to be a surprisingly and distressingly exponential curve, with cases increasing quite dramatically over the past couple of years. Human babesiosis has emerged even later, and it just in 2011 became a nationally notifiable disease. So there are no good national statistics for how many cases there are, but we know in certain areas, like the Hudson Valley of New York, that it has been growing quite dramatically.
And for Borrelia miyamotoi, again, we don't know what this pathogen is going to do to emergence of a brand new tick-borne disease. The black-legged tick, formerly called the deer tick, that transmits all three of these pathogens has a very wide geographic distribution in the United States. It occurs over much of the territory over the eastern half, and in the far western US, its counterpart, the western black-legged tick, can be very abundant. Within that area that shows potential for transmission of these tick-borne diseases, we know that Lyme disease is found clustered in a few major foci, the upper Midwest and Northeast and Mid-Atlantic states has been mentioned already. But notice from this slide, these are the last year's statistics from the CDC, if you can see the slide well, that there are a scattering of dots all over the lower 48 states. And that's the case in almost every year. We know very little, actually, about those little dots that are spread throughout the United States. We don't know whether some of those are from suburban people who live in suburban Atlanta who encountered some infected tick when they were on vacation in New York's beautiful Hudson Valley or Cape Cod, and then went back to Atlanta where they got sick and the case was reported from there. Or we don't know whether they got it while they were out walking their dog or gardening in local areas. We simply need to learn much more about those scattered dots. We also know that this disease is spreading geographically from these foci in which they first emerged. And one of the most dangerous situations is right at the edge of those dark clouds of dots, where risk locally is probably very high, but awareness is probably very low. How many people are getting exposed without knowing anything about ticks or tick-borne disease, and their healthcare providers don't know either, and so they don't get diagnosed early on, and they can have very poor health consequences as a result. And we don't know very much at all about the geographic spread, the rate of spread of these new tick-borne diseases, how climate change will increase that spread, and the like. There are several worrisome traits of Borrelia miyamotoi, this new disease on the block. We know that unlike any of the other big three of these tick-borne pathogens, that there can be what we call transovarial transmission of the pathogen. That means the mother ticks can transmit Borrelia miyamotoi through her eggs into her babies. And at 6 to 73% of newly hatched baby larval ticks are infected with these tick-borne pathogens when the situation is 0 for the other big three. This becomes a big problem, if you can see this slide, because for the other tick-borne diseases, what we tell people is you need to worry about the nymphs. This is that kind of intermediate, although quite tiny stage that's active between May and about early July. That's the time we need to really look out for tick-borne disease risk. Well, the problem is for Borrelia miyamotoi, if they occur in the larvae, which we now know they do, we really need to worry about a prolonged season of tick-borne disease risk, August, September, even into October. And we know from our studies and others that the number of larval ticks out in the woods, it can be anywhere from 10 to 50 times higher than the number of nymphal ticks. And if you think nymphal ticks are small and hard to detect, will you see or fail to see a larval tick? They are even tinier, and I'm very worried about this. There are no standard diagnostics. It's simply too new of a disease, so we don't know how many people have it. We don't really have data on the degree of threat. With my colleagues at Bard College, we have determined that we have a fairly widespread distribution of miyamotoi infection in populations of ticks that occur in areas of New York State where there are no human cases at all. So we expect that risk is actually considerable, but we have not diagnosed it because there is very little, if any, awareness of this particular pathogen. And we know from these same studies with Bard colleagues that Borrelia miyamotoi seems to tend to co-occur with the Lyme disease spirochete in the very same tick. So we can add this to the list of co-infections that a single tick bite can transmit 2, 3, or even potentially 4 different pathogens in the same bite, in the same poor patient. So where do we go from here? I've focused on a lot of the questions, a lot of the things that we don't know, and I think what we need in this country is an all-of-the-above strategy for further funding, and that's why I'm so pleased with what our senators and congressmen are pushing forward at a national level. Clearly, we need better diagnostics so that people do not go for a long period of time without being diagnosed and hence treated. And this is essentially essential for each of these tick-borne diseases, but this is, in fact, a limited approach because it is piecemeal. It is limited to each individual tick-borne disease. What we really need to tackle all of these tick-borne diseases simultaneously are innovative tick control strategies that target the ticks themselves, the culprits that are responsible for transmitting all these pathogens. I know that the EPA and the CDC do have some innovative integrated tick control strategies that they do fund, but at a very low level, and we need to increase this level of funding. We need surveillance outside the current range so that we can target areas in which awareness is low, the disease will not go well detected at an early stage, and these late stage symptoms become problematic. We need education, not just of the public, but also of healthcare providers, both inside and outside the currently known range of the disease. And lastly, I think we need basic research at the tick-host pathogen interface. I know as an ecologist that there are places that are terrible hotspots for tick-borne disease and other fairly nearby areas in which the risk is actually very low. There's something about nature that is regulating that risk. If we can harness that understanding in tick interventions to reduce that risk, we'll be far better off. Thank you very much.
Thank you for this opportunity to speak to you today, and I'm going to take a slightly different topic approach, at least, and talk about babesiosis as opposed to Lyme, and I hope to make it clear why I am when I talk about the blood supply. The list that you see before you is the list of agents that are currently tested for in the U.S. blood supply. HIV 1 and 2, HTLV 1 and 2, hepatitis B virus, hepatitis C virus, treponema pallidum, which causes syphilis, West Nile virus, and Trypanosoma cruzi, which causes Chagas disease. Now, we test all these agents using tests that have been licensed by the Food and Drug Administration. You must use a licensed test in order to screen the blood supply. Now, when we talk about tick-borne diseases, and are they transmitted by blood transfusion? And I use this slide in these kinds of forums to make it very clear why we don't test for Lyme disease. There has never been a case of transfusion-transmitted Lyme disease reported. I didn't say that it doesn't happen. I said there's never been one reported that we are aware of. And based on that, there is no need at this point, at least, to test the blood supply. Now, other agents, which we've heard about today, Anaplasma phagocytophilum, there's been 7 cases of transfusion-transmitted anaplasma. But the one we're majorly concerned about is Babesia microti, in which there's been 159 cases of transfusion-transmitted babesiosis. So that's where our interest at this point lie. And because of that, we're trying to make efforts to address this situation. But I think this goes along well with what the senators and the congressman are trying to do with a larger program to address tick-borne diseases. This is just a different one. A little bit about Babesia. The agent in human babesiosis, there's really 3 main species, B. microti, B. divergens, and B. duncani, which is found on the West Coast. There's quite a number of new Babesia popping up worldwide, and they have these alphanumeric names. Some of these are in Europe, Korea, Taiwan. We're finding more and more Babesia as people look for them. It infects red blood cells. That's actually a picture. I know they don't look red, but it's an acridine orange stain, and so you can see the parasites inside the red blood cells. They're occasionally found extracellular outside the red cells, but as I said, primarily in red cells. They're transmitted by the deer tick, as we've already heard. The same tick that transmits Lyme and Anaplasma. And it's often the same species that locally transmits Lyme borreliosis. So on the West Coast, we think it might be Ixodes pacificus, but we're not quite sure. Generally, babesiosis causes a very benign flu-like malarial illness. It's often self-cures, can be easily treated with antibiotics. However, it can be fatal in infants, elderly, immunocompromised, those with sickle cell disease, and asplenic patients. Those just happen to be some of the patients, or most of the patients, who get blood transfusions. So rather concerning, rather significant disease to us. Just for interest, I throw in a life cycle. You can find some very nice life cycles on the CDC webpage of different diseases. And actually, to my knowledge, this is the only life cycle the CDC has that actually includes a obvious blood transfusion as part of the life cycle. So they acknowledge that this is a major concern. And as we heard, it is now a notifiable disease since 2011. This paper came out in 2011 and really was a rather important contribution that came out of the CDC. And it's really made a lot of difference in people's thinking and actually bringing this issue to the forefront. And it's entitled Transfusion Associated with Babesiosis in the United States, a description of cases. And it describes in a 30-year period 162 cases of transfusion-transmitted babesiosis. 159 of those cases, as I already said, was B. microti, which we have in the Northeast and the Upper Midwest. And the other 3 is the more obscure B. duncani on the West Coast. The median patient age in these transfusion cases were 65 years of age. Again, that reflects the fact that people getting blood transfusions tend to be older. Primarily associated with red blood cells transfusions, although there have been cases in people who have received platelets. They have, or at least disease has thought to have contributed to observed fatalities. I'm not saying that these patients died of babesiosis, but 28 of those people in these cases died. They had babesiosis, which may or may not contributed to their death. In any case, when you look at these numbers, this likely undercounts the number of actual cases. Certainly, there's a lack of physician recognition of the cases, and also based on case selection criteria. What is a true case? What is a possible case? And so forth. And it's also important to note that 87% of the case have been in the 7 endemic states, 2 in the Upper Midwest and 5 in the Northeast, where babesia is primarily found. This is a bar graph that came out of that paper I referenced from the CDC, and it's a bar graph of the cases over the last 30 years. And as you can see, there was a relatively few cases per year through the 70s and the mid-90s. It ramped up in the late 90s, early 2000 to about 10 to 20 cases. But then you can see a really dramatic increase within the last 5 or 6 years in the number of cases. So it really points to the fact that this is a growing problem. One thing is sometimes discussed, well, maybe this is only a problem we need to be worried about during certain times of the year, during the tick season, during the summer months when it's being actively transmitted. And as you can see from the CDC case reports, there are transfusion-transmitted babesiosis cases every month of the year. Certainly there's a peak in the summer months, but it can happen anytime during the year. So what are we doing about this? How are we seeking solutions, at least for babesiosis? Well, first of all, from our perspective, babesia poses some unique challenges. Unlike the other agents which we test for, and I showed you that list earlier on, babesiosis is largely a regionalized issue at this point, as we understand it, in the Northeast and the Upper Midwest. There's been limited test development to date. Keep in mind what I said in that first slide. In order to test the blood supply, we must use a test licensed by the FDA. We can't use a diagnostic test. We can't use blood smears and those kinds of things. And manufacturers, to some extent, particularly the normal manufacturers of blood tests, have been reluctant to develop a test because they perceive this perhaps as a potentially limited geographical market because it's only in the Northeast and the Upper Midwest. And they may not recoup their R&D investment, so they need to be encouraged to develop this. Well, in response to this, the American Red Cross, other blood collection agencies in the U.S., for instance, like the New York Blood Center here in New York, and the FDA are actively addressing this issue, and I think we're really making some good progress. Blood screening tests is certainly a viable option, much like we screen for HIV. There are antibody tests or nucleic acid tests that could be used to detect the presence of babesiosis. And as I keep coming back to this point, however, tests must undergo rigorous clinical trials and be licensed by the FDA. But the good news is there are currently 2 tests that are being evaluated under investigational new drug applications with the FDA. So they're generating data, clinical data, which they hope these companies will submit to the FDA for licensure. So I will at least leave you on this positive note, that I think a licensed blood screening assay may be on the horizon in the not too distant future. So hopefully we'll have addressed this issue. Thank you.
Okay, so I am very happy to be here, and I'm going to share with you some good news. And the good news is the news from science, which is that I believe that science has, over the last 10 years, a lot of the advances that have been made is really creating a bridge between the academic ivory tower and the patient community that has been suffering. And for a long time, as we've heard, which one? This one? Okay. Yeah, so for a long time, as we've heard, the Lyme patients who have had Lyme disease are suffering tremendously. This is from William Blake. This is Job, who's been suffering, and nobody knows exactly why Job is suffering so much and why he's been afflicted so much. And his friends start to attack him and say, you must be making it up, or you must be being punished because you did something wrong. And patients actually begin to feel this way. They feel like people are accusing them of making it up, and it's not real, and you can't see it, and doctors don't know what to do. Family members start to fight one another. It's a miserable illness, and oftentimes people are told, they go to the doctor says, well, Lyme disease is always curable with a short course of antibiotics, so this can't be Lyme disease. Or they say that, well, you had Lyme disease, but you don't have it now because you got the curative amount of antibiotics, and any remaining symptoms must be something else. Go see the psychiatrist. So the psychiatrists and mental health professionals often see these patients, and they say, but this isn't psychiatric. This is something medical. Go back to your medical doctor. Or they say, if you've gotten better with antibiotics, it must be a placebo effect. So this obviously is a torment to patients, and it's made them very unhappy. But the good news is that research is now creating a bridge. So I'm just going to highlight a few of the research set of studies that are serving to create a bridge. And I think this is a really wonderful one that Borrelia, and very interesting, learning that Borrelia can persist. In the mouse model, in the monkey model, in the dog models, and so many animal models, it's been shown now that despite what you do after you give antibiotics, you can still find active organisms. That doesn't necessarily mean those organisms, those spirochetes, are still causing disease, but now we know at least that the Borrelia can persist. So where research is right now is trying to figure out what those persisters, what those persistent organisms are doing, if anything. Are they causing disease? Are they able to come out of dormancy and then reactivate and cause disease or not? So that's the beginning of a bridge in terms of basic science as to why patients might have persistent symptoms. Another interesting thing we've learned is that Borrelia detection requires special techniques. So if you do those mouse studies and you take the blood of the mouse and you try to find the spirochete by PCR or by culture, you're not going to be able to find it using the standard techniques. However, if you take our enemy, the tick, and have a clean tick and have it attached to the mouse and feed on the mouse, then oftentimes a spirochete can be detected after treatment because of this particular method called the xenodiagnostic method. So the tick is better at detecting the spirochetes than the humans are. And now there actually is an NIH-funded study being done jointly by Adriana Marquez in the intramural program and Tufts University, where they're actually looking to see, can we find Borrelia, persistent Borrelia, in patients with chronic symptoms using the xenodiagnostic method. So some very courageous and brave patients are going up there and letting ticks feed on them. And I think this will be a very informative study. So I want to congratulate the NIH for actually funding that study, because that's obviously looking forward, and it's true translational medicine. There have been some repeated antibiotic trials, and as there have been two, Klempner did 2 trials in one, and his studies did not show any benefit, but there also have been 2 studies that have shown benefit. So this is a bar graph of the main results of Krupp's trial, which was a study of post-treatment fatigue, in which everybody got 1 month of IV antibiotics, and the primary endpoint was 6 months later. And what she found was that 60% of the patients given the IV ceftriaxone were better in terms of improved fatigue compared to 18% of those who got placebo. And then if you look for a biomarker, our goals, we all want biomarkers to predict who's really going to get better if you give them more treatments. She looked at those who were IgG Western blot positive at the start of the study, and then the rate of improvement or responder rate went even higher to 80%. We, in our study of Lyme encephalopathy, which is cognitive impairment after Lyme disease, used that data the same way that Krupp used her data and re-examined our data, and what we found was the same exact results that Lauren Krupp found. So in a sense, it was a type of repetition. So that suggests that at least in some patients, repeated treatment can be very helpful. It also shows that about 40% of patients aren't getting better. So the question is, what do they have, why aren't they getting better, and how can we help them? So one thing that's been very interesting over the last 5 years really has been studies showing that there's a heightened immune response in these patients. Armin Aladini, Dr. Aladini, who was here at Cornell and now is at Columbia, has shown that persistent symptoms are associated with increased antibodies against neural proteins. So there's elevated numbers of antineuronal antibodies in these patients, comparable to what you see with lupus, and vastly higher than what you would see with healthy controls. So there's something going on that's activating their immune system. Another study done out of his group in collaboration with Dr. Crow here at Cornell showed that sera from these patients, from our patients actually in our study, induced a higher expression of interferon genes. And why is that interesting? That's interesting because alpha interferon, when you give it to patients, causes fatigue, it causes brain fog, it causes irritability and depression. And so this study actually showed that patients with post-treatment Lyme syndrome have an elevated expression of alpha interferon. And then we did a proteomic study looking at the spinal fluid antigens to see if it's different in the post-Lyme patients versus chronic fatigue patients versus healthy patients. And what we found is that indeed there are unique differences. And there were like 690 different unique proteins in the post-treatment Lyme patients, but also shared proteins of elevated complements. So again, another marker of a heightened immune response in these post-Lyme patients. So the question is, why do they have a heightened immune response? Is it persistent infection? Is it persistent antigenic material from the prior infection? Is it an autoimmune thing? These are all really important questions that are driving current research, and it's very exciting because I think it's going to lead to helpful treatment approaches. And we looked at brain imaging. I mean, the notion that it's all in your head, go see the psychiatrist. Well, maybe it is all in your head because the brain is the central computer of the body. The immune response is partly governed by the brain. So much is governed by the brain. And here we find that there's deficits in specific regions in the post-treatment Lyme patients compared to healthy people. And the regions that we found as being abnormal are regions that modulate pain, the insula, regions that modulate memory, the hippocampus. So and could there be an interaction between the immune system and the brain? The answer is yes. And these brain regions may be working abnormally because of what's going on in the immune system. So if you can modulate the immune system, you might be able to modulate what's going on in the brain. Finally, not all tick-borne infections cause Lyme disease. As you know, Powassan virus was found in 2% of the ticks in Westchester County. Powassan virus can cause a deadly encephalitis. Serious diseases. So future directions, we need more studies on Borrelia persistens. We need diagnostic tests that can detect active infection. We need treatment study of patients with persistent symptoms, which include non-antibiotic approaches. And we need studies to identify biomarkers that will predict treatment response. Finally, we do need better education, because these are really exciting findings, and most doctors don't know anything about these findings that I just reported. Thank you.
Thank you very much. We're going to take a little break in a minute, but before we do, and I think we're going to lose Senator Blumenthal, before he goes, I wanted to ask a question that was sent from our friends up in Ulster, which I think is best answered by them. And the question is, what can citizens do to expedite passage of Lyme legislation at state and federal levels, and to get the CDC to change recommendations so that insurance companies cover treatment for longer term than the recommended guidelines?
Well, that is an excellent question, and I'm going to ask Congressman Gibson also to answer it. because it deals with, I think, the realm of influencing or impacting our political process. And the answer is very simply, look at the areas where those dots have begun to appear in high congestion. More simply, look at the areas where Lyme is beginning to spread because, as was remarked very, very pertinently, in those areas, risk is high, awareness is low. Those senators and congressmen are likely to have Lyme, if they're aware of it at all, very low on their radar screen, so to speak. But its incidence is growing. They ought to be aware of it. I said to Senator Gillibrand when that remark was made, we ought to be contacting our colleagues who are from those states, because we have on our bill, as I think maybe is true in the House as well, the senators who are from the states where blue is dominant, but in those other areas, and maybe in those areas where you have a small number of dots, senators and congressmen should be aware. So the simple answer is, really, on this kind of issue, calling, writing, emailing can make a difference.
So thank you, Senator. And I just concur, we got, there's two targets here. The first one with regard to the Tick-Borne Advisory Group is really our colleagues. And we will work this day and night to expand out the number of folks who support, but there are things that do help. As the Senator mentioned, if you have family or friends or other advocates in other areas that have also been impacted, reaching out to them and asking them to contact their representative helps us. Same, we have media here today. And raising awareness to this should also help us get more allies. Because you know what? This legislation costs almost nothing. I mean, it is so small when you're talking about the impact here. Tens of thousands of dollars will make a difference here. And I think we're talking $100,000 for the entire advisory group. This is minuscule compared to how much we can save. But beyond that, just in allowing folks to live a flourishing form of life to their potential, as the testimonies that were given here today. So that's number one, the target being our colleagues. Number two is with regard to the CDC. So the Senator and I sidebarred moments ago where we talked about how our staffs are going to work together. I had mentioned that I had previously sent a letter along with two colleagues in the House, but I think it'll be more effective if it's not only bipartisan but bicameral, that we ask the CDC. You heard just some of the testimony here today. If the guidelines were updated to reflect what's breaking in this field, we will make a difference. So, you know, just in terms of focusing, in terms of better testing, better treatment, and better coverage from the insurance company. So I appreciate the question from up in Ulster, and we'll continue to work it, and we can work it together.
And just one last point. Congressman Gibson's absolutely right. We will contact the CDC. We've done so on the Senate side as well, but working together, I think, would have a more powerful effect. But, you know, let me just state to you a basic truth about this disease. There is nothing as powerful as an individual story of a victim. That is what has affected, I think, Senator Gillibrand and myself. You know, I was, as I mentioned earlier, first contacted by patients. When you talk to young people, when you talk to people like David Roth or any of the people who are here today, and I'm sure there are a number who have been afflicted by this very, I call it pernicious, I call it an epidemic. It is both. And they have a powerful story that will impact your congressmen and your senators in a very personal, direct way. So the more you can use those stories, real life stories showing the consequences of this disease, the more powerful it will be.
So
and I apologize, I've got to.
Thank you so much, Senator. I just wanted to mention that on the website of the Tick-Borne Disease Alliance, which is www.tbdalliance.org, we actually have the ability for you to go to an advocacy section of the website, and there's software that allows you to produce an email that will go to the appropriate senators, congressmen, and other public health officials. You can customize it to tell your story. I didn't know this about the political process, but these days with email, there are actually people in everybody's staff who actually collate and look at how many emails come in on any given topic. And it can really, I mean, you can comment on this, but it can really make a difference if we can get out from the grassroots level how important this is for the constituents within each of these jurisdictions.
Absolutely. Absolutely.
So we're going to take a 10-minute break. Thank you to everybody. We're going to come back with some Q&A shortly.